Hi, my name is Atif Darush, professor and consultant of obstetrics and gynecology. Imagine yourself going to the OR to perform a case of combined laparoscopy and hysteroscopy. The nurse will ask you a question. Which procedure you will start with? Laparoscopy first or hysteroscopy first? So you have to think, I need to do laparoscopy first because something I plan to do, or I need to do hysteroscopy first because of some advantages of starting by hysteroscopy. Now, this topic is not well covered in literature. I'd like in this short lecture to highlight the advantages of starting by laparoscopy or hysteroscopy. So if you decide to start by laparoscopy, because laparoscopy is, of course, a good procedure to give you a comprehensive idea about the pelvis and female genital organs, it helps detect the associated lesions like pelvic endometriosis adhesions, and it can be used to monitor my hysteroscopic surgery. So it is very advantageous to start by laparoscopy. Moreover, it confirms the original diagnosis and reveals any cause of pelvic pain, for example, and can detect some lesions, as I already mentioned, like endometriosis or ovarian cyst or pelvic adhesions, as proved in some old studies. And laparoscopic monitoring and detection of perforation or prediction of perforation is another advantage mentioned in this publication. I can add some technical advantages of doing laparoscopy prior to hysteroscopy. During hysteroscopic procedures, if you look to the uterus, by laparoscopy, you will find it moving in an aggressive way due to cervical dilatation, particularly in cases with stenotic cervix, and also during hysteroscopic maneuvers by resectoscope or operative hysteroscopy. So laparoscopy can control the process of manipulations of cervix and uterus and direct the hysteroscopist to avoid any unneeded procedures or any complications. Another advantage of laparoscopy is that at the end of laparoscopy, we inject methylene blue as a chromoperturbation test. And this staining of the endometrial cavity is an advantage from my point of view, rather than being a disadvantage. So this is another advantage of laparoscopy. So I would like to start by laparoscopy. Also, I published a review article on the endoscopic explanation of unexplained infertility to highlight the advantages of combining laparoscopy and hysteroscopy, and to show that laparoscopy can add to your diagnosis, particularly in cases with infertility or unexplained infertility, like visualization of fine peritubal adhesions, mesosalpingeal factors, peritubal coiling or adhesions to the lateral pelvic wall, subtle tubal endometriosis, uterine causes of tubal factor, isthmic causes. It can detect the range of tubal motility and tubal Douglas pouch relationship, which is the site of ovum pickup. All these are advantages of doing laparoscopy. So why to start by hysteroscopy? Because laparoscopic procedure followed by hysteroscopic procedure has some disadvantages. Now, the other doctor will say to the nurse, no, I'll start by hysteroscopy first. Why to start by hysteroscopy? Because the risk of anesthesia is less when I start by hysteroscopy, no pneumoperitoneum, and less cardiorespiratory stress of the prolonged procedure of combined hysteroscopic and laparoscopic operations. The second advantage of starting by hysteroscopy is the positioning of the patient in the dorsal lysotomy position and avoidance of Trendelenburg with less risk of air or gas embolism. Good access to the cervix, particularly if a patient with a previous repeat section. And this is actually a real advantage of starting by hysteroscopy if the cervix is taken up or high cervix due to previous cesarean sections or previous pelvic operations. The adhesions will take the cervix up. If you inflate the peritoneal cavity with pneumoperitoneum, your access to the cervix is difficult, and sometimes you cannot reach the cervix unless you make deflation of the peritoneal cavity to make the cervix accessible for your instruments. Also, the hysteroscopy first saves time because it can detect some intrauterine lesions that may explain abnormal HSG, for example, polypi, myomata, or some adhesions. So it can help diagnosis and cut short the process of diagnosing a case of recurrent abortion or infertility. Also, hysteroscopy does not need prior extensive dilatation and cannula insertion for injection of the dye. And these procedures actually will lead to endometrial damage, and excessive bleeding can occur, and this can hinder proper visualization. The last advantage of doing hysteroscopy first, because we don't inject dye, so we will get clear view. And actually, this is not an advantage. This is a disadvantage. Why? Because you should know that the endometrium, normal endometrium, is non-absorptive endometrium and does not take up the stain. So if you inject the dye into the normal endometrial cavity, no staining of the endometrium. And actually, methylene blue stains only damaged cells. The cells and their membranes had to be damaged to allow methylene blue dye to reach the cytoplasm and stain the nucleus, as mentioned in some publications. And methylene blue staining is a chemical contrast medium or agent that provides imaging enhancement and allows identification of specific epithelia or highlight subtle mucosal irregularities as commonly used in the gastrointestinal tract endoscopy like colonoscopy or gastroscopy. And this is actually using methylene blue to stain epithelium is pioneered by the GIT doctor. So if you inject methylene blue into the normal endometrium, it will not be stained. You will find staining of the abnormal endometrium. And this publication showed intrauterine adhesions are stained by methylene blue, while the normal endometrial lining is not stained. And another study used methylene blue to determine the abnormal and pathologic endometrium and to search for endometrites in the endometrial cavity by injecting 5% methylene blue and waiting for 5 minutes until the cells are stained by the methylene blue if they are pathologic, and they took biopsy. And actually, this study did not find any correlation to endometritis, but others found some correlation with the dark blue staining more than light blue staining after injection of 1% of methylene blue and waiting for some time before taking endometrial biopsy. Others used 2% solution concentration and again waiting 5 minutes. So the advantage of non-use of methylene blue should not be put in your mind. Using methylene blue is an advantage prior to hysteroscopy to see the normal endometrium and abnormal endometrium. So if we look to the disadvantages of hysteroscopic procedure first prior to laparoscopy, you will find that you made an extensive intrauterine surgery like myomectomy, septal incision, or adhesolysis. And after this extensive procedure, you will inject dye for laparoscopy second. So intravasation of dye will occur. And many studies or case reports reported on intravasation and the green urine sign due to systemic absorption of methylene blue after hysteroscopic procedures, even in those case reports after a few days or weeks after the hysteroscopic procedure. So hysteroscopic procedure will lead to intravasation of the dye, and you cannot assess the tubal patency properly after extensive hysteroscopic surgery, because the dye will go to the blood vessels after cutting the myometrium, and so you cannot assess the tubal patency, and you will say to the patient after your procedure that she is in need of tubal patency test like HSG, and this is not good. So if you do tubal patency testing prior to hysteroscopy, you got the advantage of anesthesia, and you made tubal tubation test prior to hysteroscopic procedure. Another disadvantage of doing laparoscopy after hysteroscopy is that in some cases, particularly after extensive uterine surgery like extensive myomectomy or septal resection or incision, particularly if you made some sort of over-treatment, as you can see in the lecture on the over-treatment and under-treatment of septum. And some case reports found a uterine rupture after septal incision due to the dye coming to this site of incision, and the uterus has been ruptured, and this is a great disadvantage. Also, if you do hysteroscopy first, you will lose the benefits of laparoscopic monitoring. Why to lose the monitor of your procedure? You are not 100% person. You can have some complications like perforation, false passage, and so on. So if you lose the advantage of laparoscopy and do the procedure, blind procedure, and then you will do laparoscopy, you lost the monitoring, and it lost the prediction of complications and prediction of perforation. And even if perforation occur while you are doing laparoscopy, the vital organs will be away from the uterus, so less risk of injury of intestine or so, and no risk of energy dispersion if you are using monopolar diathermy, because the assistant will make the intestine and vital organs away from the uterus during your procedure. So all these advantages are lost because you stressed that you will start by hysteroscopy, not laparoscopy. So these are common disadvantages of starting by hysteroscopy. In short, I would like to say that when a combined laparoscopy and hysteroscopy procedures are planned, I think it's better to start by laparoscopy than to do hysteroscopic surgery. Because of the previously mentioned advantages. Also, you have to reduce pneumoperitoneum to the absolute minimum before hysteroscopic procedure. I mean, after finishing the laparoscopic procedure, you have to minimize the pneumoperitoneum, because extensive pneumoperitoneum unneeded, because you will do hysteroscopy, and this can have some respiratory and cardiac impairment for the patient. So you have to minimize the pneumoperitoneum to the minimum before you go to do hysteroscopic procedures, and you can re-inflate if you need to monitor the uterus or the assistant cannot see the uterus properly to the minimum to avoid extensive pneumoperitoneum and avoid more exposure to CO2. And lastly, you have to prepare yourself to the benefits of using methylene blue staining of the uterine cavity to see the normal endometrium and to see the abnormal endometrium, and to take biopsy from abnormal endometrium. And these are the advantages of doing laparoscopy first. Thank you very much.